So the first question is going to be for Dr. Maluccio. Thank you for the excellent presentation on the role of transplant. So in your experience, Dr. Maluccio, the role of transplant, I'll present a scenario potentially. So a patient with stage 4 pancreatic neuroendocrine tumor with primary tumors in place, it's grade 1, it's non-functional. There's liver metastasis that are not amenable to resection, innumerable, so to Dr. Liu's point, more than 10. In the liver and no role for debulking. So you put the patient on capecitabine and temozolomide, and they have a phenomenal response to the point where the tumors in the liver are of millimeters. When would you consider a transplant if you would consider a transplant? Earlier, later, middle?
Yeah, so that's a loaded question. So you'd have to have told me what the indication for the CAPTEM was, because if the Ki-67, in the U.S., we're allowed to go up to a Ki-67 of 20%, the person has to be less than 60 years old, and there has to be a disease interval that is deemed acceptable. So my issue with using neoadjuvant, or, we kind of use the term neoadjuvant. So neoadjuvant chemotherapy in patients that we're ultimately considering transplant on is the likelihood that that response in micrometastatic disease was as good as the response that you had in the area that's going to be transplanted. So the criteria are that you're going to have to at least prove single organ dysfunction. And then if you say, for example, so we say innumerable, I would say miliary. So if you've got miliary, which is like these grains of rice type thing, very difficult to treat with liver-directed therapies, highly likely to have liver-related morbidity. And so the difference between 10 and 510 is very different when you're making that decision, because liver-directed therapies are highly effective and can buy you considerably more time. So I would be choosing liver-directed therapies prior to consideration of transplant in a somatostatin receptor avid tumor. The new controversy is whether or not you would have to at least consider PRRT prior to transplant. I think it's going to lean that way, that you would have to have at least something that is tried and true in randomized trials, have either not be appropriate or had not worked. Do you have any, Mr. Madden?
Thank you. Maybe Dr. Anthony, Dr. Wolin, maybe you can give an example of a patient that you have referred for transplant and kind of what the scenario was. Dr. Wolin, have you referred anybody for transplant? Have you referred anybody for a transplant, and what was the conditions and situation?
Well, the answer is yes, I have, but the indications are getting to be very, very limited, as Dr. Maluccio was just telling us. Interestingly, when I was in California, the liver transplant team took a look at all the patients that they had ever operated on for liver metastases from neuroendocrine tumor who met the criteria for transplant. In other words, low-grade tumors, confined to liver, good enough physiologic function, they could have a transplant, and they met the criteria that would be appropriate for a transplant, and the ones that are accepted in the United States and in Europe, the criteria. And then took a look at how long these patients lived and how well they did. And it turned out that with debulking surgery, embolization of the liver, PRRT, systemic therapies, we'll be talking more about different kinds of things tomorrow that are possible. These patients had a median survival that was at least as long as was ever possible with transplant. So you have to be very selective of who gets a transplant and what is the risk and what is the benefit. As you've been hearing, the risk and benefit analysis is so important. You don't want to cause more harm than good. You want to do the best you can for everybody. So the people that need a transplant are often young people who have liver failure resulting from complications of previous treatment or from the disease and have no alternative but a liver transplant or die. those kind of people would be somebody who, there isn't even a question, transplant is high up on the list. So those are the kinds of people that I've referred in the past. And do you have any comments on that?
No, I would actually make one other comment. So the metastatic PNETs, or when we shifted from a multivisceral transplant to an upper cluster where we do a liver panc, the reason why we did that is that most of the things that drove perioperative morbidity and mortality and outcomes was the intestinal part of the multivisceral transplant. So by eliminating the intestinal part, which is the driver of post-transplant rejection episodes, I think the overall survival expectations for an upper cluster is much longer. So I think that, although I agree, it's usually going to be that we have either a complication and or the likelihood of single organ or bi-organ failure. But as Eric had a great shot, the total mesenteric thrombosis or the sinestral portal hypertension, where you have all those, what did he call them? Ginormic, like Goombas in the squiggly worms or whatever. That can actually be very difficult. That's a life-limiting problem in and of itself. And so that would be where you would end up considering it earlier, because then you're really trying to prevent that complication.
That's great. Really helpful, because it's really tricky on the timing of transplant and kind of, when to talk about that, when to be referred. Is that an option for you? It's a big endeavor, but, it potentially could be, life-changing for that individual. So next question I will direct to Dr. Mohammed. So the question is, so a patient goes to have a surgery for a neuroendocrine tumor, and they are being monitored with the CT scans, at intervals that are determined by the oncologist. The patient would prefer to have a dotatate scan. How would you counsel that patient in terms of if the dotatate's needed, or what would be the situations where you would want to get a dotatate in that setting?
Sure, that's a great question. So before I go to this point, referring any patient to surgery, as Eric just mentioned, for what we call cytoreduction or debulking, usually, definitely, we discuss this patient very carefully in the neuroendocrine tumor board. We just published a paper very recently summarizing all the data, which all of them are exclusively retrospective. None of them is a prospective big trial, for example, to compare the cytoreduction with medical therapy. But obviously, this patient definitely benefit from cytoreduction. So basically, we definitely discuss this patient very carefully. Some factors will affect the decision of cytoreduction include the grade. For example, if someone grade 2, 10% or more, I will deal with him different than someone with a grade 1 or grade 2, Ki-67 less than 10%. It also depends how much tumor bulk, and all these factors will really affect our decision for sending this patient for cytoreduction or not. But all the papers across the retrospective data, it did show improving the outcome. The mainly improving the outcome was for patients who had 90% or more of debulking. Recently, we have about 3 or 4 papers showing that if you can get at least 70 or 75%, you have very comparable outcome. But very comparable outcome for the overall survival and progression-free survival, how long it will take for your cancer to progress again. But the overall idea definitely reset the clock from the beginning, very helpful for patients with a grade 1 and early grade 2. How to follow up this patient? When you look at the NCAN guidelines and the NANETS and the ENETS, the first imaging you are going to start with and the imaging you are going to follow up with is anatomical imaging, which is triphasic CT scan or MRI if the patient have liver mets, because this is type of imaging you are going to very accurately measure the lesions and the progression of disease. But the functional imaging with the somatostatin receptor PET scan, it's more functional. It's more not to measure the size of the lesions. Otherwise, it will tell you if these lesions having somatostatin receptor, which is predictive for a lot of our treatment like somatostatin analog or peptide receptor radionuclide therapy. It also, in some time, more than 20% will show you more lesions that you can see it in the anatomical scan. So if we need to summarize everything, the imaging you are going to start with and follow up with is the anatomical scan, and you can consider repeating the PET scan if there is some new lesions or some uncertain lesions that you are not aware of.
Thank you, Dr. Mohammed. Yeah, I completely agree. You know, the PET scans, I mean, they're expensive, and if they're justified, that's fine. But you should really have a good reason to do it. You get false positives, and then you start chasing your tail, you know, in terms of you find something and it's not really something. But if something comes up on the CT scan or the MRI that is suspicious, then getting the PET scan is justified. Right? So it's not that as the oncologist we don't want to get the PET scan or we want to be like adversarial. We just want to make sure that we're getting it for the right reason. And I think that comes down to, like, you know, just education. You know, why would we get the PET scan as opposed to what we call cross-sectional imaging, where we can actually measure things and we could see it better, right? Because when you do a PET scan, you don't even give contrast, right? You just give the radionuclide, so you know you're getting a suboptimal diagnostic scan. Okay, so let's go to a question for Dr. Anthony. So if you have a patient that comes in and they have a pancreatic neuroendocrine tumor that's in place, and they had an endoscopic ultrasound-guided biopsy, and you made the diagnosis, and they also have liver metastasis. Are there any situations in which you would recommend a biopsy of not only the pancreas, but also the liver?
So whenever you do what's called EUS, endoscopic ultrasound biopsy, it's cytology, really. It's not really a biopsy, and it's the aspiration. You get cells, you don't get architecture. So then in the world of trying to understand biology, just having a few cells isn't always ideal. We try to get more tissue, then we have to decide how to go about doing that. Do we do it at the time of a surgical procedure? If we have that, those few cells will get a dotatate scan right there. And we'll work it up more and make sure the somatostatin receptors expressed. So if everything looks uniform between the primary and what's in the liver, then it becomes more how much do you have to support what your eventual clinical decision is going to be. So it depends on where in the pancreas it is. If it's in the tail of the pancreas, and we know that that lesion eventually is going to grow and cause problems, then we know that we're headed towards having that excised. I don't know who does that. Maybe our radiologist does it, or maybe, I don't know. But Eric Liu. But the approach here is, do you know the Ki-67 index from the few cells? How bad do you need to know the Ki-6 index from a few cells? Can you go ahead and start treatment on the liver, debulk the liver, and then go after the primary? And so there's a lot of decisions that have to be made. How much of the liver is involved? Is there extrahepatic disease in addition to anything else besides extrahepatic disease in addition to the primary? A lot of questions. So yes, I think I would like to have new tissue, but I think we have enough information to start the process of understanding what the disease is.
Dr. Wolin. Thank you, Dr. Anthony. Did you want to comment, please?
Just a quick comment. It's the most common way to diagnose a pancreatic neuroendocrine tumor. The most common way to diagnose a pancreatic neuroendocrine tumor nowadays is an endoscopic ultrasound with that fine needle aspirate. And as Dr. Anthony was saying, you just get a few cells, the so-called cytology. The problem is Ki-67 refers to the percentage of cells undergoing cell division, and you can't calculate an accurate percentage when you have only a few cells. And you could be tremendously misled in the grade of the tumor. And remember what you heard earlier about grade 1, grade 2, grade 3. You could think you have a grade 1 tumor, but it could really be a grade 3. So as Dr. Anthony said, you can start treatment based on that, but watch like crazy for what happens. Because if you have a, let's say a CAT scan that shows a tumor, you start treatment, and then a few months later the tumor's tripled in size. There's no way that's a grade 1 tumor. It wouldn't triple in size in a few months. It's definitely a higher grade tumor, and you definitely have to get a good biopsy that's not just an aspiration of cells, like a core biopsy of the liver. So it really depends on the clinical circumstances. If you have enough information to start treatment, and let's say this was a pancreatic neuroendocrine tumor and you were starting treatment with CAPE-TEM, and the tumor was responding nicely, and then the plan was to go ahead and have surgery after that and take it out, you'd get really good pathology at surgery. You wouldn't need that liver biopsy. But if you have any disconnect between the clinical picture and what the pathologist originally told you, by all means get tissue ASAP so you know what you're treating. I've seen all kinds of misdiagnoses made on cytology. Sometimes it's not even neuroendocrine. Sometimes it's a different grade. Sometimes it's not what you think it is. Thanks.
Yeah, that's some great wisdom. And, reiterating why seeing a NET specialist is so important to kind of tease out these nuances. I was just speaking to a patient. We were looking at their PET scan, and it was a dotatate PET scan. And there's an area in the liver that was lighting up on the FDG PET scan, but not the dotatate PET scan, suggesting there's heterogeneity. There's a difference in biology of that same tumor within the body. And you have to be able to appreciate the fact that, the tumor's not going to behave all the same. And so these are justifications for getting biopsy. So next question for Dr. Liu, in regards to surgery, whether it be a Whipple procedure, whether it be a cytoreductive surgery, one of the questions was, what is the expected recovery in terms of, what to expect as far as how long, potential, this patient seems to have been experiencing long ongoing discomfort, abdominal discomfort.
So unfortunately, everyone's different. So assuming you don't have any complications, right? You could have pneumonia or a heart attack or a stroke, or sometimes you get a leak. When you do the operation, things can leak because it didn't seal or heal very well. Assuming you didn't have a complication, it can take, you're in the hospital between 3 and 10 days, depending on what operation you have. You may have drains coming out. Usually people after about 2 to 3 weeks are feeling not too bad and functioning around. And once they recover by about 6 to 8 weeks, they're feeling pretty good, pretty normal. But that's a very, very generic description of it. We want people to be up and walking around in the hospital. So within the first few days, we want you up, moving, and vertical, because that helps to reduce pneumonia, it helps to reduce, helps to increase your appetite and your bowel function and things like that. So the more you can do, the faster hopefully you can recover. And the more we can hopefully avoid any complications, the faster you can recover. There's also one very important point. If you walk into surgery strong, then you're going to do better. If you walk into surgery weak, when you have lost 25 pounds and your muscle has wasted away, and you have chronic pain and you're on opiates, that's not a super way to walk in.
Thank you. Yeah, it points out how each individual is going to be different in terms of their recovery. I've had patients with ongoing abdominal discomfort. I mean, you disrupt nerves and, whatnot when you do surgery. So I've had patients try acupuncture or scar therapy, which is a kind of physical therapy. So there's a lot of things that we can do, and that kind of brings up the role of palliative care that, we had a discussion about in terms of maximizing quality of life. That's what palliative care is, and everybody wants that. So the next question for Dr. Mohammed, this one's a tough one, admittedly. When you're seeing a patient and trying to determine whether it's a functional tumor versus a non-functional tumor, and say the patient has a small bowel neuroendocrine tumor with metastasis to the liver, and they have diarrhea, what is your typical algorithm? How do you evaluate whether they have carcinoid syndrome-related diarrhea or something else?
So actually, this will be my talk tomorrow. So
yeah, we knew that,
definition of functionality is basically hormone plus symptoms. So you need to have elevated hormone associated with symptoms as well. When it comes to neuroendocrine tumors with carcinoid features, we have to identify what is the cause of this diarrhea. Is it because the patient in the shots for a long time, they start getting pancreatic insufficiency? Does the patient already had surgery of a small bowel and they develop short bowel syndrome, which is causing this diarrhea? Is this like bile acid, absorption problem? or these maybe other malabsorption problems that we need to work it out. But if it is associated with high serotonin, especially the plasma 5-HIAA or the 24-hour urine, and the patient has the kind of diarrhea description that fit with the carcinoid features, and the 5-HIAA was high, and also the patient have diarrhea, most probably the patient will have what we call functional tumor or carcinoid feature because of the neuroendocrine tumor. It's about almost 30 to 40% of the patient. Literature range from 20% to 40% of the small bowel will have a functional tumor. That's in opposite to the pancreatic neuroendocrine tumor, which is almost 60% of them are non-functional. So I think putting in our mind that there are many causes of diarrhea, it's not necessarily always being the neuroendocrine tumor is functional. It is very important when we do the plasma 5-HIAA or the 24-hour urine to make sure that your patient follow a specific diet restriction. You give them the list of the food and medications to avoid, so to make sure it's not false positive, and associated and excluded all other causes of diarrhea. When you do that, and the only thing left is elevated 5-HIAA, and the patient have associated diarrhea, specifically description with the carcinoid features, that's most probably, this is the right reason for that. And about 25 to 30% of these patients will have another symptom in addition to diarrhea of the carcinoid features, whether it's flushing, wheezes, coughing, and stuff like that. So I think going through the causes, exclude other causes first, make sure that the patient have a right 5-HIAA level, and then you can attribute that with the carcinoid features.
Thank you. Yeah, my practice would echo that. You know, it gets a little bit more difficult with flushing, admittedly. Historically, we actually don't even think that flushing is related to serotonin per se. There's a bunch of other substances that are produced by neuroendocrine cells, substance P, histamine, prostaglandins, all of these kind of alphabet soup of substances. So the flushing can be a lot more tricky because you check the serotonin level and it's normal. You don't necessarily rule out that the flushing is related to a functional tumor. So that gets tricky. I'm always, scratching my head on this one. There's about 30 potential causes of flushing to work through. This question's for Dr. Wolin. It's a question regarding the risk of a secondary cancer once you've been diagnosed with a neuroendocrine tumor. Is there a higher risk of developing another cancer once you've been diagnosed with a neuroendocrine tumor?
That's really a terrific question. I think that we have to think about pancreatic neuroendocrine tumors and intestinal neuroendocrine tumors a little bit separately. There are many familial conditions that can lead to pancreatic neuroendocrine tumors running in families, and those neuroendocrine tumors also tend to be multifocal, and you can get more than one. So, for example, if you have MEN1 or VHL or several other conditions that can run in a family, you can get foregut neuroendocrine tumors like pancreas neuroendocrine tumors, lung, stomach, duodenum. Those kinds of things can happen, and you can have multifocal pancreatic neuroendocrine tumors like one of the slides that we saw earlier with 5 tumors or 6 tumors in the pancreas. That type of thing happens in MEN1. And sometimes you can also get other kinds of cancer. The intestinal carcinoids are often multifocal in the sense that you could have multiple primary tumors, typically in the small intestine, that can happen usually at the same time, but occasionally you can even find some of them happen later. And up to 25% of patients can have more than one primary tumor. So you always have to look carefully for that. And that's not uncommon. But was there also a question about whether you get different?
About like colon cancer, breast cancer?
But colon cancer and breast cancer and other cancers. Okay, so people that have neuroendocrine cancer seem to have more breast cancer than other types, than other people. They seem to have more colon cancer. They seem to have more of other diseases. There isn't a specific gene mutation that's been associated with that, although there probably is one, but we don't know what it is yet. But there are other kinds of cancers. So the bottom line, if you're diagnosed with a neuroendocrine cancer, it doesn't mean that you don't have to think about other kinds of cancer or that you're immune to other kinds of cancer. On the contrary, you may be even more susceptible. So if you're diagnosed with a neuroendocrine tumor and the expectation is you're going to live for a long time, And that's all of our expectations for everything that we do to treat the disease. You want to keep up with your mammography, you want to keep up with your colonoscopy, and you want to keep up with other cancer screenings because other things can happen, and if they do, you want to find them early and nip them in the bud. Thank you.
Yeah, if I could add something to that, because I don't know what the other members of the group is. We certainly see a lot of renal cell. So I think part of the answer to the question is the fact that we survey people for a long time, so 10 years, and so you're picking things up that may or may not have been picked up had we not been scanning you every 6 months for 5 years and then annually thereafter doing colonoscopies for a multifocal mid-gut that you needed to survey the small intestine. But I will say that when I first arrived, Woltering said, you got to figure out why all of our patients seem to get renal cell over it. And so I think we were just picking up on cross-sectional imaging small, early-stage renal cell cancers that may or may not be of any clinical consequence, but we're ablating a lot of renal cells.
I've had actually the same experience, and it's interesting. That's something we see, just like we're picking up lots of meningiomas, which are benign tumors on the surface of the brain that have tremendous somatostatin receptor expression, and just by doing dotatate PETs, we're finding unexpected meningiomas very commonly.
Thank you. That was a really comprehensive kind of overview, and the highlights the importance of doing your regular cancer-related screening. And just to remind you all, they changed the age for colonoscopy to 45 from 50. So I'm approaching that, so I'm gonna have to start thinking about that. So Dr. Maluccio, question is, what is life like after a Whipple procedure? How do things change for a patient after a surgery like that?
Well, isn't that Eric Lou's question? He was the pancreas person.
To recover.
Both of you.
He's got to recover, and then I've got to tell how they're going to live. No, I would say that physiologically, so there's somewhat of a debate on whether or not if we save the valve that goes from the stomach to the first portion of the intestine, we call that pylorus sparing. I think that 6 weeks later you have a lot more normal physiologic recovery. If you do the classic where you take portion of the stomach, you ultimately have maybe a different type of recovery, but you can go and to really quite normal life. It's all about the perioperative, and after 6 weeks or so, it's sort of a done deal, and you just accommodate. I don't know what that zebra's doing, but.
What and I'll ask Dr. Liu on this one, as we have a zebra running around here, for some comic relief. I love it. What percentage of your patients are on pancreatic enzyme replacement after a Whipple procedure?
Almost all of them. So I have a basic protocol in which we just give them the pancreatic enzyme replacement therapy, and then we see how they do. And we're always happy to turn it off if they're doing fantastically well. But sometimes they just need it and we leave it on. It's one of the safest medications we have. It's a little bit of a pain, it's expensive, but it works very, very well. And the only thing I tell people that you can do is underdose on pancreas enzyme. You can almost never overdose on it, so we just do it.
Thank you. Yeah, probably a under-recognized, underappreciated source of diarrhea, bloating, gas after eating, just general feeling unwell. You could pick up on it right away. You don't need a special test. You don't need to test for fat in the stool, or send them to GI. I mean, you could just pick up on it right away you could just listen to a patient and listen about symptoms and know what's going on. And maybe a follow-up question to that for Dr. Anthony. What percentage of patients that you have on somatostatin analogs are on pancreatic enzyme replacement?
Very few. So when we developed the somatostatin analogs, we knew that pancreatic insufficiency was one of the limiting features of the product. So it's to be expected. It's normal to have pancreatic insufficiency. In fact, when I started my career, I was told that if I gave too much octreotide that people would go into fat crisis, steatorrhea, fat. They would all become fat deficient and be like a nutritional problem. But we didn't see it And we got the doses up to 6 grams a day. We do 2 milligrams 3 times a day. And we saw that the fact that we did increase the fat in the stool, but it plateaued off. We put 14 people on 100 grams of fat diet, and that's a lot of fat. You try to eat 100 gram fat in one day. That's a lot of fat. Yeah, there's a bucket of fried chicken or so. And we found that about half of it, believe it or not, I mean, we were very compulsive. We're very anal about this. And we found that, but if you gave somebody a 100-gram fat diet on 6 milligrams of octreotide a day, they would waste in their stool somewhere between 40 and 60 grams. That means that their body retained 40 grams of fat. Well, you only need 10 to 15, so they were getting 3 times the amount of fat when we were overdosing them to as much as we could. This is all published data. Octa Oncologica, these are the days that I was working with Oberg, you know. And so we put that myth to rest, and people were telling me, oh, you're going to put them in thyroid, they're going to fail because they're going to go into thyroid hypothyroidism and all these hypopituitarism. None of that happened. So only octreotide causes problem. If they have weight loss and pancreatic insufficiency on octreotide, yeah, try it. But they got to have some weight loss justification, almost like a Whipple. But we don't induce it. But if in that category, if they really get severe, I will try it. And in the early 90s, we were putting a lot of people on replacement enzymes, and we found that it didn't really work. But there's a subset, a very small subset that it does, and I'm sure Ed will probably say that he's seen that small subset.
I see it fairly frequently in my practice. I think that a lot of people don't have a problem at all, but people that are having a lot of gas, bloating, floating bowel movements, oily scum on the toilet water, and all of these manifestations of fat malabsorption. And they're really feeling fairly miserable because they have very urgent bowel movements many times a day. And you can treat these people with a nutritional supplement, essentially, pancreatic enzymes in a capsule to use before you eat. You can try it, and if all the symptoms go away and people feel much better when they're taking it and their bowel movements return to more of a sense of normalcy, you've really helped them a lot and improved quality of life. So in people who are having classic symptoms, I don't hesitate to use it. And I have people, many people I see every day who use pancreatic enzymes and feel happier doing it. The people who don't feel happier doing it don't take it because it means taking pills before you eat every single meal and every single snack, and you have to be so conscientious with your pills. So unless it's helping you, you would never want to go around carrying your Ziploc full of enzyme pills. But if you need it, you really need it, and it really helps, and people love it. So I think it's very individualized.
Yeah, can I weigh into this? Is going to be the most controversial. It's the whole debatable talk is pancreatic enzymes or no pancreatic enzymes. Dr. Dillon from Iowa gives a great talk on this very thing. He does not. We do not routinely use pancreatic enzyme supplementation. He uses over-the-counter that has a much lower dose, non-pharmaceutical strength pancreatic enzyme supplementations along with other intestinal enzyme supplementations. And I will tell you that I think our patients like that a lot better. So not to put Digest Gold out there, but he's like the diarrhea guy. You could probably hear a podcast, but that he kind of debunked it. He says, I think it's just a reflex because we believe that we drive them into pancreatic insufficiency when you can probably just eat smaller, more frequent meals, don't load up on the 100, grams of fat, and use something that's over the counter and not so expensive.
I agree with that as well.
Yeah, I want to definitely just add something. I definitely agree with that. We usually go with the diet modification first, and maybe only less than 20% of my patient on pancreatic enzymes. And always remember that octreotide or lanreotide, the most common side effect is gas and bloating because these slow the motility. So if it is not associated with the other pancreatic insufficiency symptoms, you shouldn't be in pancreatic enzymes. But if they have all the classic symptoms, we start with diet modification, and then we add the pancreatic enzymes after that.
Yeah, this was great. I learned something here listening to the panelists speak. Sometimes the pancreatic enzymes are super expensive, so that can be prohibitive as well. But the over-the-counter pancreatic enzyme sounds like and papaya enzymes, yep, I've recommended those as well. So, I'm going to start keeping that in mind more. It's kind of the lower dose. It's really fat digestion, and you really need lipase. Lipase is what you're looking for in the pancreatic enzyme. Amylase, you get it from your saliva. What the lipase is what you really need. Well, fantastic. I think we're coming up on 5 o'clock. So I want to thank the panelists for their wisdom and their patience with answering all the questions. And for you all for hanging in there for pretty long question and answer and lectures. So this was great.